All right, so this is the last of the 2022 MEC minutes, and as per our routine, we're going to do the December MEC minute on the protocol for next year. So this is the protocol review for 2022, and really it's going to be focused mostly on those substantial changes that have made to the protocol, and there are a few of them. So, what we're going to talk about is we're going to talk a little bit, maybe a slide or two about ResponseSoft and some of the changes that are coming with the app. We're going to talk a little bit about the 2022 protocol assessment, which will be rolling out soon and which we'll expect everybody to do. And then we'll also go through the major revisions or additions, and in some cases deletions of the protocol for next year. And this is a protocol that's going to be in effect January 1st at 0001 in the morning. So a couple thank yous first to the protocol committee chaired by Chief Weber from Truro, and with some special thanks to Granville Township. Lieutenant Hussey and his crew spent a lot of time looking at the clinical standards and gave us a lot of tips in terms of how to make them better. So in terms of ResponseSoft, the protocol for 2022 will have a new protocol number. So when we get close to 2022, you should get a reminder that you need to update the protocol, and you may need to actually enter the new protocol number. We'll distribute that to you as soon as you have it. So your first shift in 2022, take out your device and make sure that you delete the old protocol and add the new protocol with the number that we'll provide you. The protocol will also be able to make some drug doses calculations for particularly pediatric patients. It has been able to do that for a number of years, but now in 2022, it's also going to provide drug volume for administration for pediatric patients. So similar to Antebi has some additional things to it that ResponseSoft won't be able to do. But if you have a pediatric patient and you put in the child's estimated weight or actual weight, it will calculate the drug dose for the child as well as the volume of the medication, so that if you have to give the patient a certain amount of meds, it'll tell you how much volume for the concentration you have in your drug bag. And then if you look at ResponseSoft, there have been some formatting changes to the pharmaceuticals and procedures pages. They're just a little prettier in how they look. Actually, I think they streamline things and make things easier to understand. So we're going to move on. The protocol assessment will come out hopefully by the end of December. At this point, the timeline is such that we'll expect everybody to complete it by the end of January. Actually, January 2022, not 2021. Mistake there on my part. This is a pass-fail assessment. You have to take it, but we're not grading it. You have to participate in the conversations. We want you to review the assessment because we're using it as a learning tool. Beware that often we focus on these assessments on those things that are new for the year that we're talking about. I encourage this to be a group activity. I think it's better if everybody sits down and spends the amount of time it takes to go through the assessment and talk through the questions so you come up with an answer. But think about that and think about how you're going to do it as a group activity. And I encourage the company officers to really focus on getting this done and organized. Dr. Stoner and I will put together a video review, similar format to the MEC Minute, like we do every year. It usually is a 60 to 90 minute discussion, and we go through the questions and come up with our reasoning for why we picked the answers that we pick. So if you look at the protocol, and the protocol has been distributed to the EMS coordinators. If you haven't seen the 2022 protocol, ask your coordinator where is it, ask them to send it to you. And you should be able to go through it. And we're talking about what's a PDF or a printable version. So this is the pre-release, but it's not going to change. At the back of the protocol on pages 367 to 69, there's a list of the protocol changes. It talks about all the different things that we've made as changes, and a lot of the changes we've made have been focused on the clinical standards and adjusting the wording to make it more clear. So I'm not going to go through every change that we make. That would be a drawn-out process. It would be painful for everybody. But if you look at the protocol changes, look at the list. It's 3 pages. It'll update you on what we've done. There's a couple things we've deleted, and these are things that we did mostly with the clinical standards. So we deleted provider credentialing. Provider credentialing is not going away. It's going to be a separate document issued through my office. In January, it's going to be a standalone through the MEC EMS archive. And so it really, I think, would be better if we take it out of the protocol. We had the CERT protocol, the surgical emergency response protocol. In it, we took it out mostly because everybody I've talked to within organizations who've called for the CERT response do not get a CERT response. And that's not that's not a reflection on Columbus Fire. Columbus Fire always has a truck available for us. It's a matter of getting a surgeon in the vehicle and getting them out into the field. Often the surgeons, when they're available, are on duty at the hospital and they can't leave the hospital, otherwise there's no trauma surgeon in-house. So we just took it out of the protocol. It just didn't work for us. And then the MFATS board position statements, for several of our clinical standards, we had the position statements embedded in the document. I just took them out because those position statements periodically get updated, and then it's possible we could have an old statement embedded in the protocol. If you ever want to know about a MFATS board position on a subject, go directly to their webpage or contact me, and I can get you the statements if they're available. So moving on to some of the specific changes. It was interesting, somebody brought up, hey, we have abdominal pain is one of our most common complaints, but we don't have a protocol for it. So I thought, yeah, that's probably a good idea. So we went back and went to Gordon Griggs at ResponseSoft, and we asked them for protocols on abdominal pain, and this is what we have. We have one for peds, we have one for adults. They're very similar. Really the biggest differences have to do with drug doses at the bottom and considering doing a 12-lead electrocardiogram for patients who have upper abdominal pain. But I do want to point out these areas what I've bracketed, and they're very similar. Key components, key questions, key things to consider if you're assessing a patient for abdominal pain. So if you look at the box above this, it talks about allergies, medications, when did the pain start, and so on. But I threw in as these boxes in the brackets questions that really are things to think about asking because they represent potentially high-risk conditions. So if they're vomiting blood, if the patient's constipated or having diarrhea with black tarry stools, always think about a female patient with abdominal pain, could they be pregnant or have complications of pregnancy? So have they had a menstrual irregularity? Have they had a missed period? Is there any possibility they could be pregnant? And I would take that line of thought down as low as a 12-year-old female. I mean, we do have occasionally 12 and 13-year-old females who have abdominal pain and happen to be pregnant. So it does happen. It seems like the age keeps getting younger and younger, but think about it. Think about fever. Think about trouble with urination because they could have a UTI and be septic and have a fever. Think about and check the abdominal abdomen. I mean, if the patient has abdominal pain, you should at least look at it and palpate at it. I mean, is it distended or not? Is the patient tender in any one spot? You have to take a look. You have to assess. And then in adults, particularly older patients, always think about a cardiac source of pain, particularly upper abdominal pain. So if you have a patient with epigastric abdominal pain and they are older, I highly recommend you do a 12-lead electrocardiogram on these patients because they could be having an inferior MI that is manifested by having GI symptoms. And I know once or twice a year in the emergency department, I will see a patient with abdominal pain. I get a 12-lead electrocardiogram and it's an inferior MI, and that's the source of their pain. So always think about, could this upper abdominal pain be related to a cardiac event? Think about doing a 12-lead electrocardiogram. Children, very similar, less likely to have a cardiac event, but always think about children and think about those things can be causing their abdominal pain. And then we have medications that are called out, and really the doses are the same doses you're used to using. We just now have them as part of a protocol for abdominal pain. Probably the biggest change that we have is we're adding cardizem or deltelizem to the protocol for Afib with RVR. Some of our experienced medics have finally worn me down, and I've agreed to put it in the protocol. So cardizem is added for Afib with RVR, and this is where you're just going to see the change. So this is a blown up picture on the right of what's at the bottom left of the other diagram. And yes, you can consider adenosine as part of your treatment for patients with tachycardia, but if it looks like Afib with RVR, you can go directly to deltelizem or cardizem intravenously and bypass the adenosine. So, the dose is 0.25 milligrams per kilograms IV push or IO over 2 minutes. And these are for patients who are stable. If the patients are unstable with AFib with RVR, it's the same as any other form of narrow complex tachycardia, sedate and cardiovert. But if the patient has acute onset of palpitations, their heart rate is up, they're in AFib with RVR, and for me, I would look at over 120, over 130. I would give them cardizem, give them a bolus, and transport the patient. So look at that, and here's the section I'm talking about. So it can make a difference. Once the patient gets to the emergency department, make sure you tell the staff that you gave the patient a dose of cardizem IV, and then instead of giving the patient a bolus in the emergency department, they'll go directly to the infusion, which will start on the patients in the emergency department. So if we're in the field, we're going to give a bolus. We're not going to start an infusion. The bolus will give you time to get to the emergency department. And again, if the patient's hypotensive, not tolerating their tachycardia, it's not cardizem, it's sedation and cardioversion. I like to spend a little bit of time on the medication since it's new. Please make sure that you read this drug page. But essentially, ditolizum or cardizem is a calcium channel blocker, and it basically slows the heartbeat down. Eventually, on many patients, we start them on cardizem, and after an hour or two of the infusion, they may spontaneously convert to sinus rhythm. If you give a patient a dose of IV cardizem and they convert to sinus rhythm, do a 12 lead so we can get it checked. But I wanted to make sure you look at it. The contraindications I think are really important. We want to help patients. We don't want to give them a medication if it's going to make their problems worse. So hypersensitivity, past allergy, ask like you would for any other medication. Do you have allergies to medications? Patients with sick sinus syndrome, any type of heart block, you should avoid this medication unless they have a pacemaker in place that's functioning. So if the patient has a pacemaker in place, but they're still in AFib with RVR, feel free to give them the cardizem. If they have any indication of a heart block, otherwise do not use it. If the patient is severely hypotensive, then, again, it's not cardizem because cardizem can drop their blood pressure. It's sedation and cardioversion. If the patient has evidence of cardiogenic shock, same thing. Think about avoiding this in any patient with wide complex tachycardia. Wide complex tachycardia could be due to bundle branch block, but it could also be VTAC, VFib. Go to the wide complex algorithm. Don't use cardizem. If the patient's got an acute MI or evidence of heart failure, then I would not put them on cardizem either. The one that I do really want to point out is WPW or Wolff-Parkinson-White syndrome, and I have another slide on that. When I think about giving patients cardizem, I worry about WPW, particularly if the patient has a past history, because cardizem can be dangerous in a patient with WPW. If you're going to give the medication, there are some adverse reactions you need to think about. Hypotension can occur. If you give a patient a dose of cardizem and they become hypotensive, you give a fluid bolus, you can put the feet up. Excuse me. If they really become symptomatic, have adverse effect of the medication with hypotension, you can give them calcium chloride to reverse it. I don't think I've ever had to give calcium chloride in a patient who received a therapeutic dose of medication. I've used calcium chloride in calcium channel blocker overdoses. We're not talking about that. We're talking about patients AFib with RVR. We're going to give them ditolizum or cardizem, and I've yet to have a patient who's needed calcium to reverse it. Sometimes they get a little hypotensive. I give them some fluid. Patients can develop AV block and ectopy. Again, I can't remember the last time I've seen anybody with that as a consequence. Having said that, it'll probably happen with the first time somebody uses it in the field. I don't mean to jinx you there. And then patients can develop some side effects like vomiting, headache, and dizziness. They can develop edema if they're on this medication on a long-term basis, and it is available as a PO medication. So the one other thing I would like to say about PO medications is if the patient's already on PO cardizem, and they're in AFib with RVR, I would be very careful in administering this medication. It might be better just to package the patient and transport them like we used to do before we put cardizem on the trucks. I want to just do a couple things about WPW because cardizem and WPW do not play well together in the sandbox. So think about the patient with WPW. Look at the EKG if you have any ability to do it. Is there any evidence of this delta wave that you can see there. You can see that short PR interval, or the patient may tell you they have WPW. And it's amazing. I've had patients who come in with AFib with RVR. I start them on cardizem and they say, oh yeah, by the way, I have WPW. It's like, oh, okay, stop the cardizem. But this may look innocent enough. This patient's fine. You're gonna take care of whatever this patient's condition is. So they'll always have to think about it. So WPW's got this delta wave, which is that slurred upstroke of the QRS, and it basically gives you a shortened PR interval. If this patient develops AFib, they typically show really weird-looking tachycardias that could be wide complex. Chances are you're not going to treat them as an AFib with RVR. You're going to treat them as a wide complex tachycardia, which is okay, because our drug for wide complex tachycardia is amiodarone, which is generally safe in patients with WPW. But think about what happens if you see this. The patient's fast. This is AFib. You can still see that slurred upstroke where the red arrows are. Take a look. Always think about WPW. Always keep that in the back of your head. Look at the QRS and see if it's nice and sharp, or if there's that slurred upstroke of the R wave. And then finally, what do we do with WPW? If they're unstable, sedate, and cardiovert. If the patient is stable, it's okay to give them amio, but it may be better just to transport the patient. So patient with WPW, tachyarrhythmia, the drug of choice, if you're going to give one for what we carry, is amiodarone. Do not give cardizem. I want to talk a little bit about clearance of intoxicated patients. This is something we actually rolled out last spring, but I'm just bringing it up again. We all have times where we're called to evaluate patients that are intoxicated. They're in custody of law enforcement, and law enforcement asks, can I take them to jail, or do they need to go to the hospital? So we put this together, and it's a document that really is based upon some information out of San Francisco as well as Australia. And this is what we're going to use. This is what we have been using for clearance of the intoxicated patient. If the patient passes this algorithm, then they have capacity to refuse, they can stay with law enforcement. So if the patient has anything we call incapacitating intoxication, is any of the findings that we've got listed. So any patient who appears intoxicated and has any injury above the clavicles, they should be offered medical care. It should not be cleared to go with the police officers. This is a criterion that comes out of San Francisco, and it's been shown to be a good discriminator between sick or not sick, injured, not injured. Patients who have evidence of acute illness or injury. So a patient is having acute bronchospasm. If they're intoxicated, having acute bronchospasm, you can't clear them to go with the cops. They need to be treated for bronchospasm. If their GCS is less than 13, which means they have significant impairment, they can't be cleared. And then any patient who's got the abnormal vital signs we have listed. There's one item about active vomiting. So if the patient is vomiting on your arrival and continues to vomit, then they must be offered medical care. If they vomited once before you got there and haven't vomited since, that is not a disqualifier for clearance. If they're vomiting and you give them a dose of Zofran, you bought the ticket. That's your patient. You transport. So you crack your drug bag. They're no longer capable of being cleared for police custody. Patients can be left with a responsible person. And this may happen where, patient's intoxicated and they're with a family member who wants to take them home. Well, if the patient is able to walk unassisted, if the patient is with somebody who is responsible and sober, so, dad is drunk and the son is there and says, I'll take dad home. If he is sober, then you can leave the patient, assuming they pass all the other criteria above. And as long as you get an acknowledgement from the patient that, yes, I'm going to be left in the custody of my family member, and I'm going to stay with them until I'm sober. If the family or if the patient says, nope, as soon as you leave, I'm going to go back in the bar, they can't be cleared if you got called. An update to our freestanding psych hospital list. We've had this protocol in the books for a while. It's probably beneficial to 6 or 7 of our EMS agencies, but we did update it. At one point, Mount Carmel Behavioral Health was on the list. Well, they've not been able to meet to our standards. They're off the list. River Vista Behavioral Health is off of Alum Creek. They are new compared to when we started this process. And they also have what appears to be a very good inpatient geri psych unit, so a psych unit for geriatric patients with acute behavioral issues. So we've got Columbus Springs East off of Citygate, Sun Behavioral Health off of Bush and 161, and River Vista off of Alum Creek. I've talked with all of them individually. They've reviewed our protocol and they're willing to accept patients. I anticipate that probably in January we'll give you an update regarding how do you access each of the buildings, since after hours they're secured buildings. The one thing that we've also added to the protocol has to do with evaluation of the patient regarding their payer status. And we don't want our EMS providers to be registration clerks or have to do a wallet biopsy, but for patients who are going to a freestanding mental health facility, we need to know if the patient has either private insurance, Medicare, or any of the managed Medicaid policies like Molina or CareSource. If the patient has one of those, so private insurance, Medicare, managed Medicaid, they qualify for admission to these facilities, at least from a financial perspective. But if the patient's on straight Medicaid, they have to go through the county mental health service, whether it's NetCare for Franklin County or the other options for the other counties, for evaluation before placement. So patient who's on straight Medicaid, and there's a card picture here, they do not qualify for a freestanding psych facility as much as these facilities want to take care of them. They simply will not get paid for taking care of this patient. Same thing with the patient is uninsured. If the patient has no insurance, they have to go through the county mental health system to be evaluated and cleared for admission to an inpatient psychiatric facility. So not to belabor the point, but private insurance, Medicare, or managed Medicaid, such as Molina or CareSource, these patients from a financial perspective qualify for admission to an inpatient psychiatric facility. The other criteria that we have is a checklist in terms of, does the patient qualify or not? That has not changed. So we've added to the list of resources, we've added the brief question about what's their payer status to determine whether or not they can be admitted to an inpatient facility. Getting closer to the end, I want to talk a little bit about eclampsia, preeclampsia protocol. We've made some additions here. We have not deleted anything, we've added. So, if you look at preeclampsia or pregnancy-induced hypertension, whatever you want to use as the acronym of the week, there are really 5 categories of pregnancy-induced hypertension. There's hypertension alone, which is an elevated blood pressure, 15 points or more above baseline on 2 different occasions, 6 hours apart. We're not going to make that determination. We're going to see the patient's hypertensive, yes or no. If the patient is preeclamptic, so these are the patients who have severe hypertension, their blood pressure is 15 points or more higher, and they may also have evidence of peripheral edema, and at the hospital we'll check their urine, they may have protein in the urine, so that's another category. Severe preeclampsia is basically patients with a diastolic of 110 or higher, and have pulmonary edema, pitting edema, and so on. That's a severe preeclampsia. Eclampsia are the patients who have seizures, so pregnancy-induced hypertension with seizures. That's a common reason for you to be called. And then there's also something called HELP syndrome, which is seen in patients, tend to be in older patients. They're in the second half of their pregnancy. They have hemolysis or red cell breakdown. Their liver function studies are elevated, and their platelet count is low. That's called the HELP syndrome. Chances are you're not going to know about that patient having HELP syndrome unless they tell you they've got it. But the big addition is we are adding magnesium sulfate to our treatment for all patients who, based on any of these 5 criteria, have evidence of pregnancy-induced hypertension or preeclampsia. So if you look at the 2021 protocol, magnesium sulfate was indicated for patients who are eclamptic. They're having seizures. We're going to break the seizure with Versed. We're going to treat them with magnesium sulfate. What we've added now is we have a patient who is hypertensive. They have peripheral edema. We think they have preeclampsia. We're going to start mag sulfate and transport the patient. We're not going to wait for the hospital to start it. Typically at the hospital, we'll give a 4-gram load. We're going to do 2 grams in the field. It's a fairly safe infusion. 4 grams can be a little dicey. It's a safe infusion, but requires close monitoring. So, keep that in mind. The other thing to keep in mind is if you have a patient who's getting mag sulfate, you need to keep track of their respirations, because if you give it too fast, it'll suppress respirations. And the treatment for magnesium sulfate overdose is calcium chloride. Sound familiar? Just like Cardizem. Get into trouble, get out the calcium. So magnesium sulfate, 2 grams over 30 minutes for a patient who has evidence of preeclampsia or eclampsia. From my perspective, the patient's hypertensive and has peripheral edema. Start the infusion. If somebody doesn't like it, so what? They can call me. We're doing this because it's been shown to help patients and keep them out of trouble. I want to talk the last thing about, or the second to last thing to talk about is sedation in the patient with behavioral emergencies. I don't know if you're keeping track, but ketamine has been getting a lot of public scrutiny and media scrutiny in terms of how EMS uses it to sedate patients. There's also a lot of discussion about whether or not excited delirium actually exists as a diagnosis. In Colorado, you can't use excited delirium as a diagnosis, and you cannot use ketamine in the pre-hospital arena for behavioral emergencies. So EMS providers by law now in Colorado cannot use ketamine for behavioral emergencies. You can use it for other indications such as pain management or RSI, DSI. You cannot use it for behavioral emergency. The Central EMS medical directors, which includes me, Dr. Lowe, Dr. Cortez, Dr. Orth, Dr. Larimore, Dr. Dick, we've all put our heads together and talked about this, and we've agreed that it's in everybody's best interest if we come up with a shared procedure for administration of medications during behavioral emergencies. And we've also agreed that the shared guidelines will go in effect for our departments as we update our protocols. So our protocol goes in effect January 1st. Therefore, this protocol is in effect. I think Columbus is going to roll this out in March, and I can't speak to some of the other departments. The key thing that we require is that you must evaluate the patient before you administer the medication. You can't walk up and law enforcement says the guy's going nuts, you need to give him a drug. You have to determine that the patient has a behavioral emergency and needs the medication, and that's what I'm going to talk to on the next 2 slides. So if you look at our protocol, this is basically what we've done. This is the old protocol, whether it's for adults or kids, except at the bottom where it says behavioral sedation, we used to have the 2 branches that said violent versus agitated. Well, now we just say if the patient is suffering a behavioral emergency, we're going to do this assessment, and we're going to then assess the patient in terms of do they need sedation for their behavioral emergency. And this is what we came up with. So what we wanted to do is we wanted to tie the medication that we administer to a verified process to evaluate the patient's level of agitation. So we elected to use the sedation assessment tool, and it runs from +3 to -3, with +3 being the most combative. The patient's combative, violent, out of control, and their speech is loud and shouting. So those patients are 3. A 2 is anxious, agitated with an occasional loud outburst. A score of +1 is anxious and restless. They may be talkative, but their speech is otherwise normal. And then 0 is patient is their normal selves. And then -1 is asleep. -2 is asleep but responds to physical stimulation. And -3 is they're totally unresponsive no matter what you do. So the first part of your evaluation of behavioral emergency should be what is their sedation assessment tool score, their SAT score, and then the medications are going to be administered based on their score. So our goal is for 0 to a +1, -1 is okay. If their SAT is 1, we can either think about giving them midazolam IV or IM or IN. If it's +2, we're going to use midazolam or a lower dose of ketamine, depending on which option you want to pick. And if it's a 3, we're going to hit them with the ketamine. The IV dose of ketamine for a +3 for us is up to 2 milligrams per kilogram. Previously was 1 milligram, but we can do 2 milligrams per kilogram or 4 milligrams per kilogram IM. So check your doses here. Make sure you understand the dosing schedule for this. And then, for me, if we're going to use ketamine, the key indicator criterion is this patient violent to the point they represent a threat to themselves or others, in which case they're a +3, they're going to get my treatment. We've got some references there. We've got some things what we want you to do. So if you use ketamine, you've got to do vital signs to the best of your ability before you give them as part of your assessment. and then you check their vital signs afterwards, and you use pulse ox and end-tidal CO2 during transport, particularly if you're going to use IV ketamine. And you've got to document the vitals every 5 minutes. So at the bottom of this process, we also put a note there that this is something as a shared protocol. We think this is important in case we get challenged. It's, I think, nice to be able to pull this out and say, we've got a shared protocol. It's consensus document among the main EMS medical directors in Central Ohio. So I think this is protective and will help all of us. But again, read the protocol, make sure you know your medication doses. The last thing I want to talk about is the pelvic sling. We've added this. It's for patients with unstable pelvis fractures. You'll see that cross out on the left-hand side. I realized I was putting this slide deck together that we still had the CERT guideline listed under extremity trauma, even though we pulled it out of the clinical standard. So I'll get to Gordon, we'll get that fixed. But the key thing here is if there's controlled bleeding, we're going to pack the wound, use a tourniquet if necessary. But if we suspect a pelvis fracture, we're going to apply the pelvis sling. And really, this is a device. It's about $70. It's a single-use device. It comes in 3 different sizes, but the middle size, the mid-size, fits 90-some% of the patients in our that we're going to treat. So basically, it's a device. It's got a strap. It's a ratchet strap similar to our tourniquets, but you put the device under the patient, and you make sure you empty their pockets. You pull the strap through and you get it to click. There's a red strap that's for counter traction, and you keep clicking it until the click stops. And if you do this, you'll stabilize the fracture and you reduce the amount of bleeding into the pelvis. So if you look at the pictures of the x-rays at the bottom, this is actually the device is on. You can see the strap to the left, or at least the clicker on the left-hand side. And you can see that the pelvic symphysis, where the red arrow is close together, you take the pelvic strap off, and look, you've got this spread, and you can tell that the pelvis is unstable, and the device is actually closing this gap and is helping to stabilize the fractures and to cut back or tamponade bleeding that can occur in the pelvis. Patients can bleed out just from pelvis fractures, and this is to help prevent that. So this is a device, needs to be on every truck. It's relatively low cost. It's single use. Make sure you have it on your truck. Make sure you know how to use it. So take it out and play with it, and make sure you know how to use it. So if you have a patient with a possible pelvis fracture, you can get it on. So that's really the end of it. I think I've hit all the high points of the changes. Again, make sure that you get a copy of the protocol, start paging through it or scanning through it as the electronic version. Really make sure you look at the cardizem information sheet. You look at the updated pregnancy-induced hypertension protocol. Make sure you review and are comfortable with the sedation procedure. These are high-risk items, and you need to understand the medications. And the cardizem in particular, you should not be administering it to a patient if you haven't read the information on it and you don't have good understanding of how to use it. If you have any questions, please post them on Basecamp. Otherwise, have a very happy and safe holiday and a Merry New Year. Look forward to the next MEC Minute in January. Thank you.